Good afternoon, ladies and gentlemen. Delighted to see you all here for this postprandial session, and hopefully what I've got to say this afternoon will keep you all awake. Delighted to be here talking about the Southern Trust's work towards paperless records for patients and for clients, and I hope that some of the messages that I'm giving you strike some chords for you in your organisations. I'm happy to take questions at the end. Okay, where is the Southern Health and Social Care Trust? For those of you who are not familiar with the Northern Ireland position, the geography of the health service is aligned to 5 provider trusts, and each of those 5 provider trusts provides the full range of health and social care programmes. So each organisation is responsible for acute hospitals, for community health services, and for all social care programmes. And for mental health and learning disability. So the full suite of services across health and care are provided from each of the 5 organisations, the 5 trusts in Northern Ireland. So the Southern Trust, as you've seen, is mapped out. This is just some of the information about the trust, the size of the organisation, and you can see some of the issues we're facing in terms of the growth of our younger population, but also critically the growth of our older population in terms of the impact that brings to our services and our resources. Those are familiar statistics for each of you and many of your organisations having to deal with the demographic growth. So what is our strategic challenge as an organisation? Managing the demand, but yet reducing resources. People growing, living longer, absolutely marvellous, but with that brings then an increasing number of people with complex long-term conditions, increasing morbidity, and we all know there is a story there about how we best manage those people in our systems. In the social context, and given that we are also providing the social care programmes, the issue of the increasing numbers of older people living alone, in rural areas, isolated and without the traditional community supports, those are also key drivers for fundamental change in our system. So we need some transformational approaches. We need to continue on the journey of improving safety, and that means that we need to start predicting risk better. We need to be managing the unplanned admissions to being planned urgent admissions, taking a Kaiser approach to the unscheduled care agenda. We need to be improving the quality of care. The public are unforgiving about any failure in the quality of care, and we only need to listen to our news bulletins any day to see examples of that set out across our screens. We need to continue reducing the cost of our care, and one of the most important ways of doing that is by using technology, enabling technology, and bringing new providers into the field. We need to also find smarter ways of reducing demand, averting demand, and providing better information and communication with patients and their families about how to best use the resources that we have. In Northern Ireland, we already have an electronic patient record live in the system. We have a regional approach led by our business services organisation, and that EPR is the Orion product. It's a portal product, and we went live with that in June of this year, and so we're in that first phase of implementation. You can see the listings of systems that are already in that portal, our PAS systems, labs, diagnostics, the emergency care summary, which is the Scottish version which we implemented in Northern Ireland some years ago, also adding in A&E systems, primary care, GP out of hours, the logical first systems to get into any portal to enable sharing of information and to immediately cut out some of the duplication of tasks and diagnostics that patients are currently enduring because we don't share information. Our next phase, which will commence from the beginning of the next financial year, includes some of our specialty specific systems for cardiology, for diabetes, thinking about some of our long-term conditions and some of the demographic pressures, and also our community information systems, which bring together joined up community health and social care information. So that's the context within which all of the 5 trusts in Northern Ireland are working. So what are some of the key fundamental components of actually taking forward technology to really transform care, to enable that transformation and to make that real difference? Clinical leadership is absolutely key to making this happen. If clinicians are not aligned, if clinicians are not leading, if clinicians are not informing the way forward, then the organisation is not going anywhere very fast. Organisational leadership is fundamentally important because it needs to be freeing the organisation to innovate and be prepared to take risks. So the benefit of aligning clinical requirements with organisational goals cannot be overestimated. Of course, that brings with it the pressure of needing to deliver. There is no point in having the innovative ideas and the wonderful concepts unless the organisation can continually demonstrate that it can deliver on those products and actually implement them, embed them and optimise them. Otherwise, we're talking wasted energy and wasted resources. So how has the Southern Trust taken this forward? Recognising that technology is a fundamental enabler to transform care and to start to meet some of the increasing pressures in our day-to-day work. We elected to procure the consultancy of somebody from the ICT world who had a very deep and detailed understanding of the health world. We then, as an organisation, enabled that individual to work anywhere across the organisation, to ask all of our staff to participate in that dialogue, and we set out a range of mechanisms by which anybody in the organisation, whether they were a healthcare assistant, a domiciliary care member of staff, or a consultant in the intensive care unit, or a consultant in the emergency department, every member of staff, from whatever their position, was supported to have a conversation if they had an innovative idea, and some of the range of mechanisms are there. That produced many rich conversations, which have resulted then in the Trust having what it calls a technology-enabled change strategy. It's a 3-year strategy, long-term, and lots to do. And there are some of the ideas that are sitting in the strategy have got particular relevance to the acute world, and there are some which will have more relevance to the community world where people are supported at home to live their lives and to be supported at home. So you will see an interesting mixture of issues which relate to the different parts of the service that the Trust provides. There are 5 themes in that strategy, and I'm going to run through them very quickly so you get a flavour of what's sitting in each of the themes. The first one I have on screen here is the enabling infrastructure. Fundamentally important, we don't go very far without that infrastructure. But for anybody who's close to acute hospitals will know that that slide is really reflecting clinicians' views about what they need to do their work differently and some of their demands. Single sign-on, it's a waste of a consultant's time to be signing into 5 or 6 different systems at the beginning of an outpatient clinic. They've got to have single sign-on. We're already exploring virtual clinics. Some of our renal physicians are doing reviews of patients at home using different technology. Mobile desktop, where our clinicians can access their desktop, their information for their patients, wherever they are, in the Trust or at home. A fundamental enabler to safe, out-of-hours care. The consultant may not be in the hospital at midnight, but they can still have a conversation with the senior resident in the hospital and looking at the patient data while they're having that conversation. Our whole agenda for safety, 24/7. Computers on wheels we have in the ward, why not transform that to really mobile devices? Instead of the junior doctors at the end of a ward round having a list the length of your arm of tasks that need to be done, they're executing those tasks as they go at the end of each bed, and therefore those tasks are being ordered, those diagnostics are being ordered in real time with the decision-making process. Bring your own devices, fundamental. We are now moving in that direction with a careful first phase of access to email and a second phase of access to clinical information. But unless we can crack bring your own devices to work, we will never actually get the clinical community totally signed in. That's a fundamental enabler. Second theme is around service innovation and efficiency, and that's where a lot of excitement has rested. 2 new products that I will show you some screen slides and tell you about some functionality later on in the presentation. But essentially looking at clinical noting with a huge richness of patient functionality, the beginnings of the inpatient record, digitalisation of whiteboards and making patient flow real time, integrating that with physiological monitoring, the new scoring from the Royal College of Physicians Working Group, and then integrating that right across and forming the basis of the inpatient electronic record. But more of that in the second half of the presentation. The third theme, safety and governance. We couldn't have a strategy that does not have safety and governance at its core. And some of the topics in here you will recognise. But it's really about automating so much of what we do as manual tasks on the ward, then collating that information, presenting that in dashboards, not only to our senior management team, but to our trust board and to our external commissioners and the external audiences. How do we automate that collation of data and take that pressure out of the organisation? And of course, obviously electronic means the way to do it, but we've got to shape that, we've got to form that. So lots of opportunities here for new developments and again to link those into the patient record. At the moment we have 16, 20, 25 page assessments. They're all form-based. Why are we still doing that as a paper-based record? And again, you will all have those similar processes in your organisations. So lots of opportunities there. We already have a very significant telemonitoring programme in Northern Ireland. On any day, the Southern Trust would have 400 patients at home using remote telemonitoring and that data being viewed remotely, and then the specialist nurse getting in contact if an individual's parameters are out of their usual measurement range. We need to fully optimise that and integrate that into long-term conditions pathways, link that into ED and GP out of hours, so that those clinicians who are making decisions around the clock have got full information about the patient. We also are implementing the PARA system, which brings together core data around community health and social services, adding that then into the EPR in Northern Ireland, so that we've got the full suite of data around a patient, no matter whether they're at home, whether they're in the GP surgery, whether they're with GP out of hours, the emergency department, or in the acute inpatient ward, or in theatre. We have got that full suite of information linking it together. And the final two themes, service user engagement and employee engagement. And you can see some very strong ideas. This is probably on the 2 to 3 year horizon about how we develop patient apps, how we reform how patients get in contact with the organisation, have that dialogue, and we modernise our processes in line with the rest of the world. So lots of excitement again in these two areas as well. So how did we make it happen? Well, we looked at how we were gathering information to support clinical processes and to support safety in the hospital 24/7. Our processes were sometimes manual, they were sometimes outdated and non-sustainable systems, and they were often verbal, so therefore not recorded, not recoverable, not able to be audited, and they were bits of paper in people's pockets. So we looked at the market, and there was nothing actually out there that actually met the needs of our clinicians. We had some very clear clinical views about what they needed, and we had clear clinical champions. So we elected to work with an ICT supplier, bring the clinical champions and the ICT software developers together, and wow, we've got a very rich new product which we're going to show you some functionality from. That product allows all of the information to be configurable by the user, be that a consultant, be that a nurse on the ward, be that a junior doctor, be that somebody like myself as a director of services who needs to see at a glance information about key parameters around safety and around flow. Lots of examples of how you configure lists that just take the information that's core in the system but actually make it work for you harder, make it work smarter. The acute take lists the following morning after the acute take last night, those patients will not necessarily be in one place in the hospital, they will be necessarily in different places, they'll be in specialist wards, but how do we know and gather that list very easily, gather that from paper processes into electronic processes. The handover list, I'm going to show you an example of that later on, automatically populating the lists of patients to be discussed at the monthly meetings of mortality and morbidity, which all doctors have got to participate in as of right on a monthly basis. So, some screenshots of the products. They will only be a snapshot of some of the functionality in the products. You'll have to go and see the real products just in the stand behind you, but let's run through some of the initial screenshots. How do you get started? Well, you can start whatever way you want. Whoever you are as a user and whatever you want to look at, you can get in with your own name. You can go in with a patient name, you can go in with a ward, with a specialty, whatever way you want to get in at that moment in time on your desktop, you can get started. You can then start to look at my tasks. So as you're going around the ward, and the ward round is determining the tasks that are needed around an individual patient, the person on the ward round actually putting in the tasks in real time, and the mobile device can actually key in these tasks, can prioritise those tasks, determined by the clinical priority, those can be done in real time, and those can then be brought up at any point as a screen with that prioritisation. Notice also the right-hand column where you can say that task has been completed, and that's fundamentally important for the audit trail. Has that task been done, and therefore where are the results? And that's just something that we've got to automate into our processes. So often in manual records, we don't actually complete that loop. And then when you go back after a serious adverse incident, you find that you don't know whether that has actually been completed or not. So this is just a much easier mechanism to use within an electronic system. The handover list. Every hospital, every day, has got handover processes because no member of staff works 24/7. We know clinically that the handover process holds considerable risks for patients. It is an issue of considerable safety concerns and has been the cause of miscommunication around patients that have caused many an adverse incident. You only need to go to the evidence to understand the risks around it. So the more we can structure that and the more that we can align that and record that and therefore be able to audit that, the more important it is. So this functionality allows us to have that conversation between the consultants and the juniors, or the senior juniors and the junior juniors at the hospital at night handover at 9 o'clock in the evening at any hospital, and to actually agree what the tasks are, assign who is going to do those tasks, and then it's sitting there for the site coordinator at night to check on, and when they're reviewing that at 1 o'clock in the morning with the juniors to agree what's been done, what hasn't been done. Fundamentally important. Also fundamentally important to have a record of what those tasks were, who has done them, so that that then is an auditable record if there is any mishap in the hospital. Okay, this is a screen that starts to link in about an individual patient, about key information about their admission, about key information about them. Do they have a healthcare acquired infection? What are some of the parameters around them? And within this screen there is also some free text that you can start to add the information in about the patient and then start to think about the inpatient record. So you're starting to see not only the functionality which supports the clinical workflow and supports the staff, but you're starting to see then the core of the inpatient record. And what else would you need to have in that record? Well, news, of course. So the National Early Warning System from the Royal College of Physicians is now being embedded in this product. That is a direct lift of the scoring system from the RCP Working Party. And you can see that the individual user can key in the results on each of the parameters that form the National Early Warning Score. And then you've got a summation slide whereby the different timings of those observations, be they every 15 minutes or every hour, depending on the acuity, you can see the trend in the bottom line scores. You can see the bottom line there at 2, 15 and 7. A very worrying score of 15 because you're nearly dead at that stage. But that is the fundamental importance of this. You've got this sitting on the screen. It is then available for the staff to see. The next stage is to be able to link this up to some automated monitoring of the patient with wireless feed into this system so that the nurses are not spending a huge amount of time doing 15-minute observations. If we can automate that feed into this system with then the summary results there and then build the escalation framework that each organisation will have as to what tasks are actually expected. If somebody's got a new score of 7 or 11, that requires certain action by senior doctors in the system and the response time within 15 minutes. How do we know that's happened? If that can be keyed in here, then you've got that automated process and that results actually linked in. And again, that can be reviewed for governance purposes. So some great excitement about being able to link in the new scores around patients. Again, it's a safety and governance issue, and if we can automate that into this product, then we're a long way in terms of having the core and important data around an inpatient record. Making it happen in terms of patient flow. The old process, and one which has worked for many, many years, is paper, pens and shoe leather. And if you go and look at your local hospital, that is what you'll find. You will find bed managers who are walking and running the hospital at any point in time between the emergency department and the admission wards. And that information is only as good as the last point of contact with that bed manager. So whenever we elected to move this to something that was electronic, we needed to look and see what was in the market. We had recently implemented the productive ward part of the series of the lean approach, we'd implemented the productive ward, releasing time to care across all of our acute wards, over 30 wards across 2 district general hospitals. When we looked at the market, there was nothing that would actually lift and use that functionality, and given that it had taken us 2 years to embed that, I wasn't about to throw that out very quickly, because we had to build on what was already there, what was working really successfully, and which the staff had really taken to. So we then worked with an ICT company, Aura, and have developed then the functionality around what we had already embedded around releasing time to care, and standardised all the icons, and that is now embedded in rich in patient functionality. So we took the decision to build on what we had already embedded in the system and to make that work for us. So again, just a few screens from MX Flow. We're going to start in the emergency department. So you're in the emergency department, patient needs to be admitted, so this is the bed request screen. So the key information keyed in, ultimately interfaced with the A&E system. That request then is sitting then on the ward electronic whiteboard. So this is the electronic manifestation of the manual whiteboard. This is sitting in the ward. It can be a public screen or it can be a private screen, and you can reflect, if it's a public screen, the level of information around the patient that you want in the public domain. Or if it's in the ward sister's office, then you can display all of the information that you want. You can set the access rules depending on whether it's a consultant, a junior doctor, a ward nurse, a ward sister, or a patient flow manager. So you've got the patients in the ward, you've got the beds that are empty, and you can see that if you bring up one of the patients, you can see the range of rich information that can be colour-coded and coded by icons at a glance into that patient details. So all of that information is available at a glance in relation to each information on each ward. Now those icons, those are the icons which we have developed in the Southern Trust as part of the releasing time to care process, but those can be configured. Those can be configured by the organisation, by the hospital that you want to configure it. And you can see there's a huge amount of data you can set in there, and you can determine at a glance whether the physiotherapy assessment has been ordered, has it been started, and has it been completed. And then when it's completed, is that patient medically fit for discharge? Are they ready for discharge? Are they being discharged? And lo and behold, if it's a delayed discharge, you've got a red circle, the top right-hand corner with a cross through it, and so you know at a glance you have got delayed discharges. The enemy of the efficient hospital, delayed discharges. So you can see the functionality that's sitting there on those screens that can be pegged against each patient to support the process. So how do we see hospital at a glance? This is a new screen looking at the key performance indicators around the hospital. Again, you can read the KPIs that are there, delayed discharges, estimated date of discharge today, what your current average length of stay is, how many discharges are you expecting at the weekend, how many have you done, how many discharges do you have before 11 o'clock or before 1 o'clock. We've all got a KPI of 50% before 1 o'clock. So at a glance, in real time, you can see how you're doing. So I could have this screen in my office, I could be looking at that and then realising that at 9 o'clock in the morning or 7 o'clock in the morning, I've not got too many discharges planned for today. I know I've got a large number of delayed discharges, so I know if this is a Monday, I'm going to have a problem with bed flow. I know I'm going to have difficulty with my 4-hour targets in the emergency department because I haven't got people flowing adequately out on the discharge pathway. So that gives me a very early alert, because this is in real time, that I've got a pending problem, and the earlier I get going on it, the better. This screen can be configured by user, so it can be configured by ward, it can be configured by the bed manager, the patient flow coordinator, whatever way you need. So these icons can be configured by the organisation and again by the user. And obviously you'd want to have your own length of stay in there. You might want to have your length of stay in there, but then start to develop internal targets, that you put new targets into those screens, and you therefore ramped down your length of stay, and you then had visual alerts in the system. So lots of excitement around how best to use this screen and these KPIs in the organisation. So let's just finish with a little bit of before and after. The issues on the left-hand side, the previous pen, paper and shoe leather system, lots of potential for transcribing errors, transcription errors, handover errors, lots of difficulties in real-time communication because all the staff are busy, lots of multiple phone calls to get one patient to a particular ward. If you're in a busy emergency department at any stage in the working week, you will see, which is 24/7, you will see this happening day and daily in all of our hospitals. What we've now got is the opportunity to have real-time patient tracking anywhere in the system and to know at any point in that system what our system is. You can see the bottom table, look at the number of handoffs that we have reduced, the number of transactional interactions that have to be in real time that we have reduced. It can now be asynchronous, so you free the system, and we've really taken a huge lean approach to this process. When you see the huge reduction in the steps in the process, that is a truly lean approach. Releasing time to care, that productive ward system that we've implemented, that is the system, that is the quantification of time that we have reduced through the whole process, releasing time to care. But of course, adding the electronic solution to that has added a huge benefit to the time that is fundamentally released, because we've freed nurses from doing paper tasks with pen and paper into the electronic whiteboard. It's intuitive to use. The nurses have taken to it like a duck to water, and it saves a considerable amount of time. These are just some of the comments that we've got in terms of the whole releasing time to care process. Just read them as we go. Lots of very positives. Of course, early adopters, and of course, some of the language in the system, but that's one of the processes you've just got to go with implementing a new system. So we've built on the foundations of releasing time to care, built an electronic enabler which fundamentally supports what was already in place, but has added huge value in terms of releasing more time, but actually given us much more valuable data, and in a way that can be configured depending on what the user needs to know. Just a final example of another innovative approach to redesigning services. The two district general hospitals that I've been talking about, one has a level 3 intensive care, one has a level 2 high dependency unit. The challenge was, how do we bring the expertise of the level 3 intensivists to the patient in the smaller district general hospital 22 miles away, but not wanting to waste the time of the intensivist travelling. So 2 years ago, we introduced a telepresence robot, which actually can be remotely mobilised in the high dependency unit by the intensivist 22 miles away, or anywhere in the world for that reason. The clinician on the screen there is our senior intensivist, who can then have a dialogue with the nurse, with the patient 22 miles away, can look at the parameters, can look at their diagnostic. There's actually a stethoscope on the back of the telepresence robot, so they can listen to breath sounds, heart sounds, and they can provide advice to the physician or surgeon who is looking after that patient in the high dependency unit 22 miles away. So just another example of service innovation using technology, which means that those patients in the high dependency unit are getting the benefit of that specialist consultant's advice, even though they're not under their care and they're not physically in the same room. So just another exciting development and use of technology. So some concluding remarks. What are the key enablers to making this happen? What are the critical success factors? As I've said before, we need to align organisational goals and clinical needs to provide safer, more efficient care. Clinical champions are in every organisation. If they're not self-evident, they need to be identified. You need to harness their energy, their vision, and actually align them with the software solutions and the software developments. I've talked about a balance of regional solutions, but also some very, very important bespoke solutions, working with those clinical champions to develop systems that actually meet their needs and that they are significantly influential in bringing to the workplace. So we have a balance of best-of-breed systems, we have a balance of bespoke systems, and I suspect that balance will need to continue. And at the end of the day, who gains? Well, everybody gains, because this is all about patients and about safer care, about more efficient care for the patient, minimising the number of times they have got to tell their story in the system, minimising the number of times that any member of staff has got to key information in, Once it's in, it's used for all the variety of purposes that it needs to be used for. And of course the organisation gains because you've got a huge safe system here and one that can be audited and used in terms of reducing the governance requirements. So thank you for your time and happy to answer any questions. Thank you.